currently, and we're still in need of doing a better job of kind of trying to schedule ahead of time who's going to be on for each month. I've established a new calendar system. I'm going to send you a link to that, and if you want to look towards the future and think about something you might want to present, you can fill yourself in. We'll continue to solicit volunteers as usual, but it'd be nice to see what's coming up, and we can maybe be a little more thematic that way. And at the end of the session, we're also going to talk some more about the really kicking off the update of the mouse pathology course. And so hopefully we'll have a little time at the end to show you what I've done to try and organize that with Bob's extensive help and experience. With that, I'll turn it over to you, Jimmy.
All right. Thanks for having me, Sandy. So I'm going to talk this morning about NSGSGM3 mice, what happens when you engraft them with hematopoietic stem cells. Kind of a hot topic recently. A lot of people in this call, I believe, have published on this recently. So, I'm just going to be presenting what we found, and, we can compare notes during and after my talk. And I just think this is an important topic for us to all be aware of if we're going to be advising investigators on experimental models and whether or not, what type of mouse they should use if they want to go this humanization route. So I'll just do a little background on the humanized NSG-SGM3 or mouse, and then talk about two experiments that came through our lab at the PenVet Comparative Pathology Core, and then do some wild speculation on the pathogenesis. So in this context of humanization, I'm talking about humanization of the immune or hematopoietic system of these mice. So starting with the immunodeficient mouse recipient, usually there's a myeloablation step I think the thought is to make some room in the niche for some CD34 hematopoietic stem cells from a human donor. And then about 3 to 4 months later, you'll end up with a certain degree of engraftment and differentiation of these human stem cells in your mouse system. And so the NSG, severely immunodeficient mouse, has been around a while as a model, very permissive for engraftment of human tissues. And this somewhat more recently created transgenic NSG contains human transgenes for human stem cell factor, GMCSF, and interleukin-3. Those are expressed under the potent CMV promoter, and they're advertised as better, or kind of next gen than the NSG, and they're supposed to give you greater myeloid and Treg development and faster T cell reconstitution. You can argue that possibly the myeloid reconstitution is too great, I think. So you're on the JAX website, they say the NSG supports improved myeloid and regulatory T cell development. My understanding, kind of reading a little bit about them, is that they were developed by investigators working on myeloid leukemia, and in that case, these mice are much better at harboring myeloid leukemia xenografts. And I think maybe we're getting into trouble when we're trying to use them in these CD34 humanization experiments. So these mice came across our lab we were working with an investigator who he had this pretty cool, I think, experimental setup planned where he had a patient with glioblastoma, and his plan was to harvest hematopoietic stem cells from that patient at the same time that he harvested a tumor graft, or a tumor biopsy. And then he was going to use mice that were humanized with cells from that patient, and then do an orthotopic transplant of that tumor and I don't really know what, examined the interaction between the engrafted immune cells and the tumor graft. He works in immuno-oncology, but he never got to that point. So we had 10 NSGSGM3 mice that were transfused with those patient-derived CD34 hematopoietic stem cells and never got to the tumor engraftment, because starting at 8 weeks, mice started to become moribund. Some were found dead. Eventually, all 10 mice were either found dead or euthanized due to weight loss and dehydration. They weren't eating and drinking, really sick mice. Gross findings on the left, we've got the unengrafted control. So that's a NSGSGM3 mouse. And on the right is our affected engrafted mouse. So really severe pallor overall. You could see a little bit of the blood here. It looks more like serum contrasted with the blood of the control mouse. Lungs and kidneys really show the generalized pallor. The hearts looked a little bit big. The liver, small, kind of irregular pitted surface. Spleen a little bit big. Decreased overall visceral adipose. And we can show a decreased, pretty significant decrease in the body weight of the engrafted mice, decreased liver weight, and increased spleen weight. And our ClinPath, marked decrease in the hematocrit. These mice were in I believe one was around 8% to 20%, so really low hematocrit, almost no platelets as well.
If I may ask a question.
Sure.
So the body weights, the organ weights are all normalized to body weight or brain weight, right? Or just all actual
These are absolute organ weights.
Okay.
The spleen, when we normalize to body weight, similar trend of decreased liver weight, and the spleen weight actually is similar to and actually slightly less when it's normalized. I wasn't sure overall which is the best way to present that.
I think isn't it better to go for normalization with brain weight rather than body weight?
Yeah, I agree. Tends to change less with the body weight. We didn't collect the brain weight in this study though.
All right, thanks.
So a little bit less stark of a decrease in the white blood cells, and really small numbers overall here. This is all from the automated cell counter, so not sure how much I trust this, but a peak here of a little bit increase in peripheral eosinophils. So going through what we found on histo in the liver, you can see corresponding to that gross finding with the pitted capsular surface, we have probably some loss of the hepatic parenchyma, and you can see these infiltrates. A lot of times they were in the central lobular areas, but extending into the portal areas as well. On higher mag, they're mostly these large histiocytes or macrophages with lots of cytoplasm and frequently containing hemosiderin pigment. Here, just demonstrating their macrophage origin. CD204, so this is picking up both mouse and human. You can see it's picking up these sinusoidal lining cells here. And this is our human MHC2 marker. And we did some investigating of just how much of these infiltrates were composed of human versus mouse macrophages. And while a lot of these are human cells, here's our human CD33 forming maybe the majority of these infiltrates. There's a strong component of mouse macrophages as well. So it seems like in these inflammatory lesions in the liver, we have recruitment of both human and mouse macrophages. And here's just both of those at the same time. We have our human marker of HLA-A and red for the mouse macrophages at 480. You can see them interdigitating nicely in these liver inflammatory lesions. And we did a little bit of investigation of the markers of activation of these macrophages, and we found really strong cytoplasmic immunoreactivity to ASC picard, which is a component of the inflammasome, both in the mouse and in the using both human and mouse specific antibodies. And as far as lymphocytes, very few T and B cells. I don't have a slide of our pack. We did a PAX5, but very few CD3 positive T cells, presumed human origin here. And I'm just contrasting that here with a manuscript from 2019, where it was pretty much the same system. They just had humanized NSG-SGM3 mice, and this is IHC of the liver here, and just quite a bit more T cell rich infiltrates. So maybe there is some variability in the lymphocytic component of these infiltrates in these humanized NSG-SGM3 mice. Maybe if anybody else has looked at how many at the lymphocytic component of these infiltrates, they could let me know. Moving on, those enlarged spleens. We have these kind of areas from LOMAG here, just kind of paler staining, not as much of this these dense nuclei as in the red pulp. If we look at a little bit closer, those are very similar macrophagic infiltrates, a lot of them containing hemosiderin, and often we can see active hemophagocytosis, more so here in the spleen than in the liver and other tissues. Just another high mag here of our hemophagocytosis, and very nice positivity on Prussian blue with all those hemosiderin containing cells. And just recapitulating that here we have the cells expanding the spleen and eating these red blood cells are human origin. Changes in the bone marrow were interesting and kind of variable. In a lot of instances, you'd have whole fields taken over by eosinophil maturation, as we could see here. In other instances, there was necrosis, kind of reminiscent of infarction, perhaps, kind of acute coagulative necrosis in regions of the medullary cavity. And in other fields, less commonly found than the eosinophil maturation, we could find macrophage infiltrates similar to those that we saw in the spleen and the liver. And our trusty HLA-A is confirming that those eosinophils and macrophages in the bone marrow are those human cells engrafting perhaps too strongly in the marrow of these mice. And the spleen and the liver were consistently affected by the macrophage infiltrates, and there were rare scattered infiltrates in other organs. This is just one example of tissue infiltrate in the brain. This wasn't described in our study, but I believe, Laura, in your study, some of the mice had neurological findings attributed to these brain infiltrates of macrophages. All right, so we were a little confused as to why these mice were dying. It seemed to be, a problem with these NSG-SGM3 mice, which our stem cell xenograft core that had prepared the mice with those patient HHSC had not used very often, and they knew that the NSG mouse could reliably host these hematopoietic stem cells and give you a quote humanized hematopoietic system. So we did just a small follow-up study with that group, comparing NSG versus NSG-SGM3. We're also wondering if there was anything having to do with this particular patient, the patient that provided the hematopoietic stem cells in the first instance. So a very small follow-up study where we had 3 NSG and 3 NSG-SGM3, and they were engrafted with pooled bone marrow-derived CD34 hematopoietic stem cells. These are from adult donors, otherwise healthy. And then we just watched to see what would happen over the next 3 to 4 months. And eventually, by 15 weeks, all of the NSG-SGM3 mice eventually became sick and had to be euthanized due to weight loss. And we did find a very similar phenotype, just showing our similar decrease in body weight and marked decrease in the hematocrit and platelets. Very similar histopath findings, nothing new to show in these really. But one point I did want to highlight is that we had some more data, some flow data on the engraftment efficiency. So before, I think 15 weeks was when we ended up having to euthanize the NSG-SGM3 mice. Before that, we were wondering whether this experiment would work because at 12 weeks, the peripheral blood showed really low chimerism, and indeed at 15 weeks, the chimerism in the peripheral blood was very low. It didn't correlate well. We had really high engraftment in the spleen and bone marrow, and that was seen on our histopath slides as well. So just a caution that the peripheral blood chimerism, so the proportion of CD45 cells that are of human origin, is not always correlating well with the degree of tissue chimerism. All right, so HLH, just sharing what I've learned in my reading. Pathogenesis involves excessive uncontrolled activation of macrophages. In many patients, there's a shown genetic defect in cytotoxic lymphocyte function. So cells that are, perhaps infected with virus are not cleared, and it seems that clearance of activated macrophages is an important regulatory immune function that's lost in patients that don't have adequate cytotoxic lymphocyte functions. So these macrophages just continue, secreting inflammatory cytokines, activating each other, and they're never cleared out to provide a break on activation of the immune system. Macrophage activation syndrome, as far as I know, very similar findings to hemophagocytic lymphohistiocytosis. In some literature, you'll find the terms used interchangeably, but I believe it should be used when you have this syndrome in the context of a known rheumatic disease. Some examples given here. And clinical findings are listed here, and the ones underlined are the ones that we could show were recapitulated in our NSG-SGM3 mice of splenomegaly, bicytopenia, and hemophagocytosis. Sorry. Primary, like I was saying on the last page, we have these loci implicated in defective natural killer or cytotoxic T lymphocyte function, possibly failure to eliminate activated macrophages, vicious cycle, and secondary HLH, no evidence of genetic predisposition. Maybe there is one that hasn't been found yet, but there's often a trigger such as viral infection, and most commonly that would be Epstein-Barr virus infection. We did do in situ hybrid or Epstein-Barr, what is it, early something, Eber-ish, I forget what it stands for, but it's a diagnostic for active Epstein-Barr infection. That was one of our wild thoughts in the first group where you had these patient-derived stem cells. We were wondering if there had been reactivation of Epstein-Barr virus causing this syndrome in these mice, but that ISH was all negative. And there are some other instances where patient-derived xenografts end up harboring, latently infected B cells and causing problems in engrafted NSG mice, but I don't think that's the issue here. So a little bit more on Hlh Mass in mice. So it can be done with Epstein-Barr virus. There's a cool manuscript in 2011 where they engrafted NOG mice, very similar to NSG mice. And then following engraftment, they challenged them with Epstein-Barr virus, ended up with pretty similar phenotypes to what we had. And then HLH Mass-like syndromes, they can be recapitulated in mice both with and without lymphocyte dependence. So just kind of imagining the pathogenesis in the NSG-SGM3, is it lymphocyte dependent or not? I think we can get there either way. So in this model, mice are given repeated stimulation with CpG DNA, which antagonizes TLR9, and they get the phenotype, and works even in RAG2 knockout mice, so mice without T cells. And then there's another mouse model of MAS. So these mice have perforin deficiency. So that's one of the predisposing factors to HLH in human patients. And they don't get MAS spontaneously, but if you infect them with LCMV, they'll get it. And in this case, depletion of CD8 T cells prevents the phenotype. So they're an important part of the development there. And interferon gamma is essential in both cases. Some more examination of the cytokine milieu would have been interesting in our studies. We just didn't really have access to it. But there's some previous studies that have reported on that. And finally, just a little bit more on the NSG-SGM3 system. So this group has done a lot on the NSG-SGM3 mice. They work on myeloid leukemia, so I think that's why they've been interested in it for a long time. So the anti-myeloid, anti-CD33 therapy and interleukin-6 can relieve the phenotype in humanized NSG-SGM3, but lymphocyte depletion is ineffective. So some evidence here that the phenotype in the humanized NSG-SGM3 mice is not reliant on lymphocyte activation of macrophages. And they report a relatively low level, although I believe increased relative to controls of interferon gamma in the humanized NSG-SGM3 mice experiencing HLH. And finally, just some suspicion for the role of GMCSF. The serum concentration of GMCSF in the NSGSGM3 mice is 2 to 4 nanograms per ml, and physiologic is 20 to 100 picograms. So we have a 20 to 200-fold increase. So perhaps the superphysiologic GMCSF is causing both proliferation and possibly activation as well. Just a citation here, tying in GMCSF not only to proliferation of myeloid cells, but also boosting IL-1 production. And if we want to, we could try to tie that into the inflammasome activation, which we kind of saw with the ASC pie card. And here's just a kind of fun finding this paper from the late 80s, where they have a transgenic expression of GMCSF in mice leads to accumulation of macrophages, blindness, and a fatal syndrome of tissue damage, somewhat similar to our phenotype. Yeah, so summary, we had an entire cohort of 10 humanized NSG-SGM3 experienced this phenotype and die or necessary euthanasia. They had hepatic and splenic histiocytic infiltrates with hemophagocytosis. We had histo on 7 out of 7 of those. Severe anemia and thrombocytopenia, ClinPath on 3 of those. This was our Epstein-Barr diagnostic, was negative. And then we had our second study where we had the phenotype present in all of the engrafted SGM3 versus none of the engrafted NSG. So I'd like to thank everybody at the PenVet Comparative Pathology Core for helping out, and the Stem Cell and Xenograft Core for being involved in the study as well, and to our friend Zev Binder at the med school, whose study was unfortunately ruined, and but led us to investigate this story a little bit. It's kind of funny at the beginning. He was saying someone told him, when the vets are excited, it's usually a bad sign for your study, because when his mice were starting to die and we were finding these things, we were like, oh, this is kind of interesting. So yeah, that's all I had.